and she's going to share with us the work that she's done for her PhD, which is looking at children with perinatally acquired HIV and what happens to their livers and their liver fat content. So I'm looking forward to this. I'm sure you all are too. And I think if you're ready, Penny, you can take it away.
Yes, I'm just unmuting myself before I share, because I realize if I start sharing, then I can't unmute myself. Is that projecting?
Perfect.
Okay, great. So thank you so much for inviting me here today to present my research that I've been working on as part of my PhD. It's titled Determinants of Steatotic Liver Disease in Children with Perinatally Acquired HIV in the Era of Early Antiretroviral Therapy. So this has been quite a long project, and it's at the very final phase now. I was very fortunate as part of my PhD. I was sponsored by MRC to work for part of the time, full-time on my research. But otherwise, as all of you have done PhDs know, there's a lot of after-hours work involved. So as part of the PhD process, you end up doing a lot of work on evenings and weekends. And then when you finally see your family and friends, then they always ask you, what are you doing your PhD on? How's it going? And I think the most dreaded question of all for anyone working on a PhD, when will you be done? And basically, I had it all planned out very nicely at the beginning. And I think started very naively, as most people seem to. And then, just as I'd started, I'd developed my protocol, started working on my PhD, COVID struck. And I lost about a year almost, just as I was starting my PhD. But apparently that's par for the course. So now I'm certainly several years older. I don't know if I'm any wiser, but I have managed to produce a PhD thesis. So many people have asked me why I look at HIV and the liver. And part of the reason for this was one of opportunity. When I started out, I was a recently qualified pediatric gastroenterologist, and I was working in the pediatric HIV clinic at Tygerberg Hospital while working in the combined infectious diseases and gastroenterology ward at Tygerberg. And I thought that this was an important and neglected disease. Liver disease is the second commonest cause of non-AIDS death in adults living with HIV. And as we know, there's a worldwide increasing prevalence of obesity in both adults and children. And metabolic dysfunction-associated steatotic liver disease is emerging both in children and adults and is recognized to be a really important disease, especially in adults with HIV. But unfortunately, we still know very little about liver disease and especially MASLD in children with HIV. So if we look at what we know about pediatric steatotic liver disease, as in adults, it's a spectrum of disease. It can range from simple fatty liver, may progress to steatohepatitis or fibrosis, and even rarely cirrhosis and hepatocellular carcinoma in childhood. And the problem is it's quite an insidious disease and is often asymptomatic, picked up incidentally, or presents with complications. The natural history is still not known. It's typically seen in children over the age of 10 years, but can present in children between the ages of 3 and 10 years. And in high-income countries, MASLD is an important cause of chronic liver disease and an emerging indication for liver transplant. It's important that it's a diagnosis of exclusion. The gold standard for diagnosis is liver biopsy, which we wouldn't perform routinely, only if there's diagnostic doubt or clinically advanced disease. And also, confusingly, the histology in children is different to that in adults. Children can have pediatric type histology or adult type histology, or a combination of pediatric and adult types. And as we all know, the treatment is very unsatisfactory and still focuses primarily on weight loss and exercise. And these are difficult to maintain in the long term. So as we know, insulin resistance is very important in the cause of MASLD. We know obesity is the result of positive energy balance. Adipocytes function as an energy reserve for times of undernutrition and store triglycerides in times of excess nutrition. Leptin and adiponectin are also important for appetite regulation. But unfortunately, especially in this day and age of excess calorie intake and limited physical activity, we can find that long-term excess calorie intake can exceed the anti-steatotic potential of adipose tissue. And essentially, the adipose tissue cannot deposit any further triglycerides. This then leads to insulin resistance and eventually can lead to a pro-inflammatory state, steatohepatitis, and fibrosis. So it's not all just insulin resistance. There are a couple of other important hormones that are secreted by adipose tissue. So there's leptin, which is a peptide hormone secreted by adipose tissue. It's important that leptin regulates appetite, acts on the hypothalamus, and reduced energy intake. And importantly, just as with obesity leading to insulin resistance, you can also get leptin resistance. So as energy intake increases and the adipose tissue cannot expand any further, leptin levels increase, but you have less and less effect in terms of reducing energy intake. Simultaneously, you also have adiponectin, which is important to regulate blood sugar levels, that suppresses gluconeogenesis and enhances glycolysis. These levels also drop, and this shifts to a pro-inflammatory state. So these days, we know it's more complicated. It's not just a matter of first developing fatty liver and then after that developing inflammation. We know that it's actually a lot more complicated. So if you look at the modern theory of pathogenesis of MASLD, we know there are underlying genetic and epigenetic factors. These might be either risk factors or protective, as we know that some populations, like in Africa, the prevalence of MASLD is much lower than in the rest of the world. But it's genetic factors in combination with environmental factors. So dietary factors, obviously very important, and obesity in MASLD. And importantly, dietary factors can have an impact on the gut microbiome. And dysbiosis can lead to altered intestinal permeability with an increased delivery of bacterial products from the gut into the portal system and reaching the liver. And in addition, obesity with adipose tissue dysfunction leads to insulin resistance. This leads to ongoing lipolysis, and this releases excess serum fatty acids that are then delivered to the liver. And these can then result in ectopic deposition of fat outside adipose tissue in the liver and other organs. So you have liver deposited in fat deposited in the liver. But in addition, the increased free fatty acid flux can result in lipotoxicity. So you have intermediates such as diacylglycerols and ceramides that lead to endoplasmic reticulum stress, mitochondrial dysfunction. All of this, as well as adipokines, lead to systemic inflammation, mitochondrial dysfunction, and inflammation in the liver with apoptosis and fibrosis. So a lot of different pathways involved in the development and progression of MASLD. So if we look at this publication that describes the mechanisms of liver disease in adults with HIV, this is quite a helpful and interesting table in terms of understanding what is going on. If you look at the first column, we have the mechanisms of liver injury, and the first row, the different diseases. And I think what has helped here, you can see MASLD still called by its old name, NAFLD. What is important is that if you have a patient, it's not just a matter of either they're obese or they drink alcohol. You actually need to deal with all the possible underlying causes. So a patient might, for example, have HIV. They might also be obese. They might have hepatitis B or C co-infection. They might be on any number of drugs that have drug effects on the liver. They might also consume alcohol. And then you might also have underlying autoimmune hepatitis. So rather than thinking in terms of a binary either or model, we actually need to be thinking of all the possible mechanisms of injury that may overlap and all the possible diseases that can affect our patients. So these are some of the recent reviews that have looked at the scale of the problem of steatotic liver disease or MASLD in HIV in adults. So there's this review, A Gathering Storm, HIV infection and non-alcoholic fatty liver disease in low and middle income countries. Then another review, a review of non-alcoholic fatty liver disease in HIV-infected patients, the next big thing. And more recently, we're seeing an awareness that this is also a problem in children. So correspondence also recently, 2 years ago, fatty liver in children with HIV, a clinical iceberg. And then just over a year ago, there was this very interesting expert panel review that described the research priorities in HIV-associated NAFLD or MASLD. So they described what is currently known about the epidemiology, natural history, and pathogenesis, and what is not known. And unfortunately, there's still a lot that we really don't know, especially in terms of what drives disease progression and how we should best diagnose and treat the disease in HIV. So now looking firstly at what is already known about MASLD in children with perinatally acquired HIV. This is a summary of all the studies that have previously been published looking at children with HIV. If you look at them, they're from diverse settings, from Europe, South America, Asia, and the United States of America. A lot of them very small numbers, some of them very big multi-center cohort studies, but then that's mainly looking just at liver enzymes. It's quite a diverse range of ages, some also including adults, going up to 20 years, up to 19 years, some up to 25 years, and quite diverse in terms of mode of infection, whether or not they were on antiretroviral therapy, and how they diagnosed liver disease. So essentially, the published studies are quite difficult to compare. There are different ages included, different modes of infection. Not all were perinatally infected, some during childhood through transfusion or even during adolescence with sexual transmission. They use different modalities to diagnose disease. And importantly, not all of the children in these studies were on antiretroviral therapy, and not all were suppressed. And there was very variable timing of initiation. So if you look at these studies, they're from the USA, Latin America, Europe, and Asia, but not a single one from Africa, the region of the world with the highest prevalence and highest burden of HIV. So until now, there's been no literature on steatotic liver disease in children with perinatally acquired HIV from sub-Saharan Africa. Also no studies investigating fibroscan or vibration-controlled transient elastography in African children, and no longitudinal studies basically looking at liver disease, MASLD, in children with perinatally acquired HIV. So the cohort that I worked with was a pre-existing cohort of children and adolescents that was followed at the FAMCRU research unit at Tygerberg Hospital. These were children who'd previously been enrolled from soon after birth in either the SHIR or P1060 trials. They were either children who had acquired HIV perinatally, or HIV uninfected controls who were either perinatally HIV exposed but uninfected, or not perinatally HIV exposed. And just to give a little bit of background to these trials, the one trial was the SHIR trial, and this was a randomized controlled trial conducted between 2005 to 2008, where young infants with perinatally acquired HIV were randomized to either receive deferred antiretroviral therapy, which was the standard of care at the time, or early antiretroviral therapy from birth for the first year or two of life. And the results of this study showed definitively that early antiretroviral therapy reduces mortality among infants with perinatally acquired HIV. And this study led to the World Health Organization in 2008 advising that all infants should start antiretroviral therapy immediately. And then the second trial is the IMPACT P1060 trial, another randomized controlled trial, which compared lopinavir-ritonavir and nevirapine-based antiretroviral therapy, also in infants and young children. So these children were seen annually for a study visit. At the study visit, they had anthropometry performed, including measurement of body mass index, waist circumference, and Tanner staging. We noted all their current and past medications, whether they consumed alcohol, smoked, or used any substances. A full clinical exam was performed. At each visit, we did a fibroscan measurement of liver stiffness as a surrogate marker of liver fibrosis, and controlled attenuation parameter as a measure of fatty liver. They also had fasting bloods performed, glucose and insulin to calculate HOMA as a measure of insulin resistance, lipid profile, and also liver enzymes, including ALT, AST to platelet ratio index, and FIB4. We took note of their most recent CD4 count and HIV viral load, and we tried to test all of the children with HIV for hepatitis B and C, and eventually we managed to test 80% of them, but any child who had any abnormality of any liver, any of the liver modalities had hepatitis B and C status confirmed, and they were all negative. So if we look at how to diagnose MASLD, we obviously couldn't use liver biopsy, which is the gold standard. That would have been unsuitable for screening. So usually MASLD is diagnosed using conventional ultrasound, which we did use. We did perform on these children, and that can show increased echogenicity of the liver or elevated transaminases. And importantly, because of the diagnosis of exclusion, we performed all the necessary investigations to exclude other secondary causes of hepatic steatosis. So any child with any liver abnormality was screened for hepatitis B and C, autoimmune hepatitis, Wilson's disease, alpha-1 antitrypsin deficiency, celiac disease. We screened them on history for drugs or toxins, and importantly, in young children, we investigated for inherited metabolic diseases as indicated. But there's a little bit of a problem in that, as we know, ultrasound is quite insensitive. It only picks up hepatic steatosis if more than 30% of hepatocytes are involved, and it cannot detect evidence of steatohepatitis or fibrosis. And ALT is also insensitive. So 80% of MASLD patients will have a normal ALT, and even with advanced fibrosis, you can have a normal or only mildly elevated ALT. So Professor Pietro Vadro from University of Salerno in Italy, he's a world expert on pediatric fatty liver disease. And he said the diagnosis of fatty liver disease is a strange and annoying problem, and I tend to agree with him. So what else can we use to diagnose fatty liver disease? So there are a number of biomarkers that have been developed, but they're really not available. They're costly. They can't be applied in routine clinical use. And the simple indices that we have, AST to platelet ratio index and FIB4 index, they don't perform very well in children. So then we need to look at other imaging modalities, CT scan, MRI, also not appropriate for screening. So we opted to use fibroscan, vibration-controlled transient elastography, as we had that available. And the other options then would be shear wave elastography and acoustic radiation force impulse, which unfortunately we don't have available. So for those of you who are not familiar with the fibroscan, it's an ultrasound-based diagnostic modality where the probe of the fibroscan has got a built-in transducer that generates an elastic shear wave in the liver, and the speed of transmission of the shear wave is measured, and this gives an indication of liver stiffness, which increases as hepatic fibrosis progresses. So the more advanced the liver fibrosis is, the higher the liver stiffness will be, and the faster the transmission of the speed of the shear wave. And then simultaneously, controlled attenuation parameter measures attenuation of the ultrasound signal, which increases as fatty deposition in the liver increases. So with increasing hepatic steatosis, you will have increasing CAP. So just to show you, this is the readout that you get from the FibroScan. If you look here, there's 10 readings, which you need for a reliable scan. This is the liver stiffness, 3.8 kilopascals, so normal liver stiffness, and this is the CAP in blue. So this is an example of a normal scan, and you want to see these nice parallel lines here to show that it's a good quality scan. So the first publication then was liver transient elastography values in healthy South African children. And this was a study done to evaluate transient elastography values in healthy South African children. The reason for that is that although FibroScan is widely used in adults to evaluate for liver fibrosis non-invasively, in children, its use is not as well established. And there was a fairly recent meta-analysis describing normal values of liver stiffness in healthy Caucasian and Asian children, and they noted a lack of data from African and Hispanic children. So the aim of this study was to describe liver stiffness and CAP values in healthy South African children who were not overweight or obese, had no evidence of liver disease, no medications or medical conditions that could cause hepatic steatosis or fibrosis, and having normal fasting metabolic profiles. So we had 157 HIV negative controls. We excluded those who didn't have a valid scan, all those with obesity or overweight, anyone with raised ALT or AST to platelet ratio index, and anyone who had either raised triglycerides and low HDL cholesterol. And we ended up eventually with 104 children who were eligible for inclusion. The median range was about 12 years, and the age range was from 7 to 17 years. So these are scatter plots of liver stiffness against age for boys on the left and girls on the right. And as you can see, in boys and girls, liver stiffness increases with increasing age. And although the graphs don't show it very well because of the different scale, you can see that liver stiffness is higher in boys than girls, with the median in boys being just over 6 and the median in girls being just over 5. So we worked out age and sex-specific ranges for liver stiffness and CAP. As you can see, the 5th percentile is quite similar throughout, but if you look at the 50th and the 95th percentiles, you can definitely see older girls having a slightly higher liver stiffness than younger girls, and boys higher than girls. When we look at controlled attenuation parameter, there was no difference by age and sex. So our conclusion then was that liver stiffness and CAP values in South African children are similar to those previously described in Asian and Caucasian children. Boys have higher liver stiffness than girls, and liver stiffness increases with increasing age. So this means that we can probably use and interpret vibration-controlled transient elastography in a similar manner to its use and interpretation in children from other populations. Then the next study was prevalence and risk factors for hepatic steatosis in children with perinatal HIV on early antiretroviral therapy compared to HIV-exposed uninfected and HIV-unexposed children. So this was a cross-sectional study including 215 children, 110 with HIV, 105 controls. Median age was 14 years, roughly half were male. And again, we didn't identify any hepatitis B or C co-infection. We found that the hepatic steatosis prevalence was 9% in children with perinatally acquired HIV, significantly higher than that in HIV uninfected controls at 2%. But what was concerning to us was that the prevalence of hepatic steatosis in lean children with perinatally acquired HIV, so that is children who were not overweight or obese, was 8%. And this was despite suppressive antiretroviral therapy. And there were no lean controls who had hepatic steatosis. So we then performed univariable and multivariable linear regression analyses to try and determine what were risk factors for CAP as a measure of hepatic steatosis. So in univariable analysis, we identified BMI Z-score as well as waist circumference as being positively associated with CAP, and CD4 count and duration of HIV suppression as being negatively associated with CAP. And then when we looked at the antiretroviral drugs, we found that both zidovudine or AZT and the protease inhibitor lopinavir ritonavir were both associated with higher CAP. And in multivariable logistic linear regression analysis, controlling for age, sex, and ethnicity, BMI Z-score was identified as a risk factor for hepatic steatosis, and both higher CD4 count and longer duration of HIV suppression were protective against hepatic steatosis. So it wasn't surprising to find that higher BMI was a risk factor, but what was interesting was that it's possible that higher CD4 counts and longer duration of HIV suppression may be protective against fatty liver in children with HIV. Then the next study was looking at decreased hepatic steatosis in South African adolescents with perinatal HIV, switching to dolutegravir-containing regimens. So dolutegravir is an integrase strand transfer inhibitor that's now first line and second line for children and adults with HIV. And although it has a better metabolic profile than the other agents that are used, its use has also been associated with weight gain. So we wanted to evaluate what happened to hepatic steatosis after switching to dolutegravir. So this was an exploratory study where we compared children who remained on an unchanged non-dolutegravir containing antiretroviral therapy regimen to those who had switched to dolutegravir for a minimum of 4 months before their visit. And we only included children who were virologically suppressed throughout. So overall, there were 214 children and adolescents with HIV. Eventually, there were very few who were eligible due to many of them, especially not having had a follow-up visit yet, but otherwise already being on dolutegravir, switching to other dolutegravir-containing regimens, not being suppressed. So eventually, we managed to find 68 who were eligible, and this included 30 who had switched to dolutegravir and 38 who remained on their original regimen. So importantly, the older adolescents who were over 10 years and weighed more than 35 kilograms, they switched to combination TLD, which is tenofovir, lamivudine, dolutegravir. But the younger children and those less than 35 kgs or having a contraindication to tenofovir, they only switched to dolutegravir. So the median duration on dolutegravir was 44 weeks, so just under a year. And what we found that the hepatic steatosis prevalence decreased from 17% to 3% after switching to dolutegravir, whereas the prevalence of hepatic steatosis doubled from 8 to 16% in those remaining on the same ART regimen, and that is 84% on a protease inhibitor. So these are line graphs showing the individual trajectories of CAP. On the left is those who switched to dolutegravir, and as you can see, there was a decrease in CAP in every single individual who switched. The red line gives the median, whereas on the right, those who remained on an unchanged regimen, some increased, some decreased, but overall not much change. And of note, there was a decrease in CAP, also in those who were overweight or obese, and also a significant drop in cholesterol and triglycerides. Now, these are box and whisper plots looking, did it make a difference as to what they switched off? So this is adolescents switching from non-nucleoside reverse transcriptase inhibitors, so either nevirapine or efavirenz, or protease inhibitors. And in both cases, there was a significant drop in CAP from baseline. And then on the right, comparing the change in CAP with those where there was no switch in regimen to those who switched. Those who switched to dolutegravir there was overall a decrease in all of them, although a variable amount. Whereas for those who didn't change regimen, the median change in CAP was 0, although some increased or decreased. So overall, a significant drop in CAP after switching to dolutegravir. So the conclusion, therefore, was that adolescents with perinatally acquired HIV switching to dolutegravir-containing regimens had a reduction in hepatic steatosis, as assessed by transient elastography, with no early change in body mass index, and also a reduction in total cholesterol and triglycerides. But importantly, some of the observed effect might be attributable to switching off zidovudine and lopinavir-ritonavir, as we already demonstrated, those were risk factors for hepatic steatosis, and some also attributable to a simultaneous switch to tenofovir. Then the next study was a longitudinal study looking at longitudinal CAP and liver stiffness in children with and without perinatal HIV. So this was a prospective observational study conducted over 2 years minimum, where we evaluated the longitudinal trajectory of CAP and liver stiffness in children with perinatally acquired HIV compared to uninfected controls. We split the children with HIV further into 2 exposure groups based on their antiretroviral therapy regimen. Group 1 was those on older antiretroviral regimens, and Group 2 were those on TLD. And each of these groups was then confirmed to children without HIV. So the statistical analysis was quite complicated. A statistician did the analysis for me, but essentially we considered 2 outcomes: CAP as a measure of hepatic steatosis and liver stiffness as a measure of liver fibrosis. Both were transformed because of skewness of data. And then the results were reported as relative mean percentage difference between groups, and we modeled this as a function of HIV status. We used linear mixed effects models with child-specific random effects and single predictor analysis to explore the association between liver stiffness and each variable of interest, and we used multi-predictor analysis. So overall, we had 263 children, 112 with HIV, 151 without. Median age was 13.7 years, roughly half male and female, and the range of ages from youngest to oldest was from 7.9 to 19.5 years of age. Median age of initiation of antiretroviral therapy was 2.7 months old. So these really, they started antiretroviral therapy at a very young age, although it wouldn't be at birth, as is our current standard of care. But looking at the virological suppression, they were 96% suppressed over time. So very good adherence and suppression of viral load. And we didn't identify any participants with underlying liver disease, and all tested hepatitis B and C negative. So just looking first of all at CAP by age, this graph shows in the red children with HIV who are on older drugs. And as you can see, CAP significantly higher than both children with HIV who are on TLD, which is indicated in blue, as well as HIV uninfected controls. And in fact, what we demonstrated was that whereas CAP was 8.6% higher in children with HIV compared to controls, there was no difference in CAP with children who were on suppressive antiretroviral therapy and on TLD compared to HIV negative controls. Now, when we look at liver stiffness by age, as we know, liver stiffness normally increases with increasing age. But if you look overall, if you ignore the extremes, because there are few values there, there's essentially no difference between children with HIV on older regimens in red, children on TLD in blue, and HIV uninfected controls. And again, if we compare here in the linear mixed effects models, essentially no difference in liver stiffness between either HIV group and the HIV uninfected controls. So this shows that children and adolescents with HIV, those who were on the older regimens, they had higher CAP than both those on TLD and HIV uninfected controls. But once these children had switched to TLD, there was essentially no difference in CAP compared to HIV uninfected individuals. And what was very encouraging was that there was no difference in liver stiffness between any group. And this suggests that early antiretroviral therapy with long-term suppression of HIV viremia might protect children with HIV from developing hepatic fibrosis. So essentially, this is the first study investigating steatotic liver disease in children with perinatally acquired HIV in sub-Saharan Africa. We've demonstrated that hepatic steatosis prevalence is higher in children with perinatally acquired HIV than in those who are HIV negative, which is probably not surprising, but of concern was the similar prevalence also in lean individuals with HIV. Obesity is unsurprisingly a risk factor regardless of HIV status. But what is quite encouraging is that higher CD4 counts and a longer duration of suppression of HIV seem to be protective against hepatic steatosis. Zidovudine and lopinavir-ritonavir were associated with hepatic steatosis. Luckily, these agents are no longer part of second-line regimens. And once children were switched to dolutegravir, we found that this was associated with a decrease in hepatic steatosis, triglyceride, and total cholesterol levels. There was no early increase in BMI-Z score, but obviously we would need longer-term follow-up to be able to comment definitively on this, as that might still emerge. And most encouragingly of all is that initiation of antiretroviral therapy in early life and maintaining suppression of HIV viremia appears to protect children with HIV from developing hepatic fibrosis. So now that my PhD thesis is submitted, the postdoctoral plan is to evaluate derangements of the gut-liver axis, including small intestinal bacterial overgrowth, markers of intestinal inflammation and bacterial translocation, to try and elucidate what role this might play in developing MASLD in children and adolescents with HIV, and also hopefully to look at the association between hepatic steatosis, systemic inflammation, and markers of early atherosclerotic vascular disease. So what might the future hold? So what is encouraging is that already younger children with HIV are being initiated on dolutegravir. We know that healthy lifestyle will always be important. I think no matter what fancy drugs they might come in the future, healthy diet and physical activity will always be crucial interventions. For adolescents, we in pediatrics need to remember to think about alcohol and counsel adolescents to avoid alcohol or consume in moderation. And there are a number of future therapies emerging for those where lifestyle interventions fail or additional therapy is needed. The SGLT2 inhibitors, glucagon-like peptide 1 receptor agonists, also maraviroc and senacriviroc, which are older antiretroviral therapy drugs, CCR5 antagonists that seem to have possibly some benefit in preventing fibrosis in fatty liver, obeticholic acid, synthetic bile acid, and elafibranor. And just to give you an idea of the research that's emerging, glucagon-like peptide 1 receptor agonists, there's a lot of talk about them, both in the media and in many fields beyond the medical arena. But this is research that was done looking at the effects of semaglutide on HIV, and it's already been demonstrated that semaglutide, we know these are incretins that have a benefit in terms of potentiating insulin resistance, suppressing glucagon release, and suppressing appetite. But there's benefit for HIV in terms of suppressing inflammation and improving HIV-associated lipohypertrophy. And earlier this year, the Slim Liver trial presented results at CROI, which is one of the big HIV conferences worldwide. They showed that in adults with HIV who have MASLD, 24 weeks of semaglutide resulted in significant weight loss and 31% relative reduction in liver fat. So it's possible that in future there might be drugs available to treat our patients with steatotic liver disease. So I'd like to acknowledge my supervisors, co-investigators, and collaborators all those who've supported me or participate in the study, as well as my funders. And my presentation is over. I don't know if there are any questions.
Thank you so much, Penny. I think firstly, well done for sticking it out and doing a PhD. I think we're all in awe, seeing how much work you put in. So congratulations. The second thing I was thinking as I was sipping my wine is whether I need some TLD, but maybe I should stick to GLP-1 and agonists. So we've got a question from Zamo. So you've got to be on the ball when Zamo's asking questions. He says, thanks for a lovely talk. Did you explore the role for NPLA3 genetic drivers of SLD in this cohort, particularly the lean NASH?
So unfortunately not. So we had limited funding available, and we kind of started the PhD project and then added things in as we went along. So that's also why we didn't manage to test every single participant for hepatitis B and C. So there are stored specimens, and I think as part of the future project, it might be worth doing when we're trying to tease out the role of the gut-liver axis and systemic inflammation. But no, we haven't done that as yet.
It reminds me of the story of the thin fat Indian, which was a pair of researchers where they had the same BMI, but one had a lot more visceral fat. So are there any markers that you can look at to see whether the adiposity was more visceral?
So what we looked at really was just waist circumference, but we didn't find much difference other than between males and females. So males obviously had a higher waist to hip ratio than females, but essentially when we did all our statistical analysis and modeling, pretty much BMI and waist circumference were interchangeable. I think when they were younger, they did have DEXA looking at body composition, but I don't have any of those evaluations from them in the last few years.
See if there's any other questions. Nicholas says much appreciated. Anyone else want to raise their hand or type in the chat box? Now's the time. Well, we've got Penny online. I don't see anything else, Penny, so you might be off the hook. Let me just check the second page here. Other questions. So, yeah, again, I think I'm certainly in awe of you having completed such a big research project while you were busy running pediatric gastroenterology at Tigerberg. So well done. Also, just to wrap up, a big thank you to the Gecko New Mexico or the ECHO New Mexico team and the Gastro Foundation for hosting this. They'll also have all the recordings on their website. Thank you to the ECHO India team for the technical support. And very, very much thank you to Penny for agreeing to come and tell us about her research. And yeah, good luck with the postdoc work.
Thanks so much.
Thank you. Bye-bye.